Good morning. This is Bernardo Cortese. I'm an interventional cardiologist, mostly dedicated to coronary artery disease from Milano, Italy. I would like to discuss with you about the most impactful clinical trials that have been presented during the last TCT 2023, and those that will probably change our practice of treating our patients. I would like to start with a structural heart disease because we have two important trials that arrived at the long-term follow-up. One is PARTNER 3 5-year follow-up. This is a randomized clinical trial between SAPIEN 3 valve and SAVR in 1,000 patients at low risk. Here, low risk was defined as STS percent less than 4%. So this is a real low-risk patient population, despite the average age was 75 years. Primary endpoint was a composite endpoint of death, stroke, and rehospitalization in the study. And interesting, the completeness of follow-up was quite good at 5 years, 94% in the TAVR and almost 90% in the SAVR group. If you remember well, the 1-year outcome did show a TAVR outperforming SAVR with a hazard ratio on the primary composite endpoint of 0.52, which meant 8.5% versus 15% in the SAVR group. At 5 years, there was still an improvement in the TAVR group, 22% versus 27%, but here it wasn't still significant, the advantage in the TAVR group. But still, the signal was pretty good. If we go a little bit deeper into the details of the study, we can notice that there was a slight increase in valve thrombosis in the TAVR group, slightly more than 2% versus almost zero in the SAVR. On the other hand, there were more VARC serious bleedings in the SAVR group, as expected, and more atrial fibrillation patients in the SAVR group. From the hemodynamic performance, there was no significant difference. So this is a very important trial, 1,000 patients showing still and maintained, despite a slight attenuation of the clinical outperformance of this technology versus SAVR in low-risk patients with aortic stenosis. Contemporary, the 4-year core valve pivotal study have been presented. Again, low-risk patients, again, 1,400 patients, 74-year-old was the average age. And the results here are slightly different. There was a sustained improved hemodynamics in the TAVR group, which was at 1 year and was maintained during the 4-year follow-up. I remember that the core valve has a supraannular valve positioning, which differentiates this valve to other valves. There were also more endocarditis in the surgery group, more than 2% versus less than 1% in the TAVR group. And this is a very important information that we need to have for our patients. Primary endpoint here was a composite endpoint of death plus stroke, and it occurred in 10% in the TAVR versus 14% in the SAVR group, with a significant difference at 4 years and a hazard ratio of 0.74, which means there is a 26% relative reduction of this occurrence in the TAVR group. Very important information again. No significant differences as regards the death rate, 9 versus 12%, but again, less atrial fibrillation with the TAVR group. On the other hand, with this valve, we know that we have to pay a little bit more in terms of permanent pacemaker implantation, which was significantly higher, 24% in the TAVR group as compared to the SAVR group. So this is a very important study showing a maintenance of the clinical performance of core valve at 4 years. But I would say that both studies, the SAPIEN 3 and the core valve studies, are confirming how these two valves do not undergo, at least at 4 or 5 years, to increase risk of valve deterioration, which was one of the things that has been discussed in the most recent year. This is great news. Another important pivotal trial that I would like to discuss with you is the LIFE-BTK trial. This is just a BTK trial, scaffold, ESPRIT scaffold by Abbott versus POBA. In this study, which randomized to 161 patients. Randomization was performed 2-to-1 between BRS and POBA, and the setting is the critical limb ischemia patient. Primary endpoint again here is a composite of limb salvage plus primary patency. We have a pretty good percent of follow-up at 1 year, around 90% of the patients. Patient population, on the other hand, is not at extremely high complexity. We have diabetics in 70% of the cases, previous MI 16%, and only minority of the patients with renal disease, 16%. So not a typical patient population with critical limb ischemia, I would say. From the technical point of view, lesion length was a little bit above 40 millimeters, reference vessel diameter is a little bit below 3 millimeters, and person stenosis was 72%, so not total occlusions here. And also calcifications were not very high. So I would say that most of these lesions were type A or B following the TASC2 classifications. Which is the outcome in this study at 1 year? Primary endpoint did occur in 74% of the cases with BRS outperforming the POBA, which where the primary endpoint occurred in 48% of the cases. So BRS, good alternative to POBA in the critical limb ischemia, yes, but I have to say that this is not a typical patient population that we face every day with life-threatening lesions at the legs of our patients. So we need to see if this device can be applied also in that lesion population with a lot of total occlusion and diffuse disease. But this is a good signal. And the question is, will the company consider again to export this technology also in the coronary field? We will see in the next few years. I hope so. Then I would like to cross and go to my last two trials I would like to discuss about, which are on drug-coated balloons. AGENT-IDE for ISR trial is a very important trial that randomized patients with a paclitaxel-coated balloon agent versus POBA in the ISR setting. Here, primary endpoint was TLF, and interesting, the enrollment of the patients was interrupted after interim analysis did show the superiority of the comparator arm of AGENT after 480 patients enrolled. I have to say that here, patient population was quite complex, with more than 40% of the patients having multiple layers of stents, causing the instant restenosis. 50% of the patients had diabetes, and interesting, 70% did undergo intravascular imaging. So this is much more than what is usually done in a routine practice, despite we suggest to use intravascular imaging always in our ISR patients. How was the outcome in this AGENT-IDE trial? The agent did outperform the POBA in terms of target lesion failure, which occurred in 18 and 28% of the cases. And there was also a significant reduction in TLR and target vessel MI. So my comments about this study: this is a pivotal study for the FDA approval of the first drug-coated balloon in the coronary arena. So this is really great news for our US patients and our colleagues in the US. On the other hand, probably it does not reflect common practice, because usually we use a drug-eluting stent, at least in Europe, for the treatment of ISR. So comparator arm here was POBA and was a loser, of course. And on the other hand, also lesion preparation here was pretty simple, having been used non-compliant balloon mostly instead of special balloons or scoring balloon, cutting balloon, whatever. The last trial that I would like to discuss about is TRANSFORM-1. This is a very interesting trial aiming to assess the clinical angiographic performance of a sirolimus-coated balloon Magic Touch versus paclitaxel-coated balloon Sequent Please Neo. The primary endpoint of this study was net lumen gain. I acted as a co-chairman of the study, which was presented by Patrick Serraius at TCT. Here in the study, 121 patients have been randomized in a 1-to-1 fashion. Less than 90% actually did reach the angiographic follow-up at 6 months. But how was the outcome? So this was a real native vessel disease, but a real small vessel disease study with an average reference vessel diameter of 2 millimeters by the QCA, and it was a little bit higher by the OCT analysis, which was mandatory during the enrollment of the patients, 2.4 millimeters. Net lumen gain primary endpoint was the non-inferiority, which was expected, was not met by Magic Touch. Net lumen gain was 0.25 millimeters and 0.48 in the paclitaxel coated balloon. And there was also an increase in a late lumen enlargement in the paclitaxel coated balloon, 53% versus only slightly 30% in the sirolimus coated balloon. At 1 year, there was no significant differences in terms of clinical endpoints. I would like to do a few comments about this study. It's a small mechanistic study. There were more than double of the geographical miss in the sirolimus coated balloon. So in this mechanistic study, this difference can play a small role. And interesting, there were big differences among the centers in terms of the outcome. In 3 centers, paclitaxel was better. In 2 centers, it was the same. And in 1 center, Magic Touch sirolimus coated balloon was better than paclitaxel. So just exploratory findings. We don't know what does it mean. But on the other hand, what is reassuring to us is the good clinical performance of sirolimus coated balloon in a big population like the one deriving from Eastbourne prospective registry. And this is reassuring. But I have to say that this discrepancy between the angiographic performance and the clinical performance of this device will come out more clearly by the next upcoming studies like Picoleto 6, which will be presented next year, and by Transform 2, which is a randomized clinical trial between Magic Touch sirolimus coated balloon and Lions everolimus eluting stent in a broad population of native vessel disease between 2 and 3.5 millimeters. That's all. I hope that you spent a good time listening to my presentation of the most important clinical trial that has been presented during TCT this year. Hope to see you soon. Ciao.